Welcome, Ilya Bragin, to the Exploring Health and Medicine podcast.
Thank you for having me. Appreciate it, David.
Yeah. Would you like to introduce yourself to the listeners?
Sure. So my name is Ilya Bragin. I'm based out of the Northeast in the United States. Originally from New York City. Now I live and work in Pennsylvania. And, I'm a neurologist with a specialty in interventional pain medicine as well. For my neurology background, spent a good amount of time in hospital-based neurology. But what brought me into neurology in general is an interest in dementia and neurodegenerative disorders like Alzheimer's disease and Lewy body dementia, Parkinson's disease, and such. I also have a significant interest in technology and medicine, and of course, telemedicine, which has been very rapidly adopted in my field of neurology, particularly in stroke medicine, I would say.
Yeah. We'll be talking about telemedicine today. That's the topic of the podcast. Would you like to just define telemedicine in a very simple way so that even a 10-year-old could understand it?
Sure, I'll try. Basically, David, telemedicine is the ability to deliver high-quality medical care remotely and through distances without necessarily being in the same location as a patient. So that could be delivered via two-way video, and it could be or phone, and it could be synchronous or asynchronous, meaning the patient and the provider could be in the same place in the same time, meaning the same phone call or same video like we are right now, or it could be done with spacing and time. That's mostly seen in disorders of the skin in dermatology, where some folks can take a picture of different skin changes and send the doctors pictures of the skin changes, maybe with a description, including if there are any itchiness, pain, or burning, and then the physician can asynchronously or at a different time look at these pictures and respond with what they think this may be. Again, that's most commonly seen in dermatology, but neurology or the field where we take care of folks with problems with their brain, spinal cord, or peripheral nerves, mostly our field does rely on patient interview a lot. And so synchronous communication like this, we really do like to speak to our patients and interview them, asking specific questions, as well as doing a remote physical examination. So most of the care delivered by myself and folks in neurology is typically at the same time as when the patient is there on video or on the phone.
Right. What factors do you think are the most important ones in determining which specialties or subspecialties, as you mentioned, stroke, for an example, stroke care, that lend themselves particularly well to telemedicine? What factors of these, what properties of these specialties are important?
Well, I would generally argue that almost any field could be, at today's day and age, as technology has improved over time, you can have most fields now deliver care via telemedicine. But neurology in particular, when I really thought about this, is really, if you could do neurology via telemedicine, which I strongly believe you can, and we do fairly successfully. Neurology is an examination-heavy field, so the physical exam we really do rely on, as folks know. And so, if you could deliver high-quality neurological care, you can pretty much do almost any field. So, for nowadays, you have stethoscopes that'll send the audio recording of auscultation, of heart sounds, of respiratory or breathing sounds as well. So you have all the data you may need, depending on who is with or how the patient is able to transmit their information. But there's really no field that I think cannot be administered via telemedicine. And that's one of the reasons I wrote this paper, based on this that I think that if you have individuals on this with the patient that could help assist in the physical examination, this really opens up any field. Because if you think about, for example, orthopedics, orthopedics is a field where there's a lot of hands-on examination also, different maneuvers to test joints like knees, that the orthopedist could likely teach assistants to be remotely separated, be on the side of the patient, because you can't get every orthopedist there. It's just too geographically distributed with not enough physicians. But if you have someone on the other side that knows what they're doing, that was trained by a high quality orthopedist, you could really deliver high quality orthopedic care. And then eventually, you know, despite the distance, they could still get their imaging, whether it's x-rays or MRIs, et cetera, remotely. And so you could really get great care. And eventually what's going to happen, I think what we're seeing now is as we're getting better connectivity, both from the physician end and the patient end, with less off of data and faster connectivity, basically you'll have remote surgeries that'll be happening, which I think is where everything is moving to over time. So it's not just expertise.
Ask about that. Yeah. So remote surgeries are even it happened already.
Yeah, it's happening.
Yeah, it's happening already. So that's like a robotic surgery type of situation then?
Robotic surgery, yeah. I mean, you probably still need some, at least general surgeon on site with the patient, just for safety purposes. But at least you get the clinical expertise and the operative expertise of the subspecialists, wherever they may be originating from.
Makes sense. Yeah. So what inspired you to write this paper on? Well, can you please continue to outline the structure of the paper for the listeners, and also tell us a bit about your motivations behind writing this paper? Sure.
So the paper is entitled Certified Examination Assistants in the Age of Telemedicine, a Blueprint Through Neurology. And what inspired me to write this paper was that I was delivering, and I still deliver lots of care via telemedicine. So a lot of the hospitals are organized in the United States with what we call a hub and spoke model, where you have a central big hospital that has most of the specialists there, and you try to deliver care to smaller hospitals in the region that are still closely interconnected. In other words, we still see each other's images, we share the electronic medical record, and then eventually we transfer patients if necessary to the hub. So we really try to deliver good care to the spoke hospitals. And so when you start doing a lot of that, I was covering a 13 hospital network for quite some time. So I'd be in a central hospital, for example, rounding on patients, seeing them in person, and then I would take over the virtual care. Not just stroke, by the way, really any neurological consults. So stroke, of course, is there, but any sort of neurological derangements. A very common one, of course, is altered mental status, or change in mentation, or a patient cannot move a limb, any sort of paresis. So we cover all these pathologies, dizziness or balance changes. And so we had so many opportunities to do these kind of consults over time that I recognized that there were certain disorders, particularly gait and balance disorders, as well as what we call neuromuscular disorders, weakness. There are these disorders that a physical exam for a neurologist really helps us localize where the problem is. That's really a core tenet of neurology, is trying to first we figure out where the problem is. Is it in the nerve? Is it in the brain? What part of the brain? Is it in the spinal cord? And then after we have a location determined, then based on the tempo, we try to really hone in on the diagnosis, what may be causing it. And so the physical exam really helps us there. And we have different diseases that we see. Things like multiple sclerosis or Guillain-Barré syndrome and other demyelinating disorders. And I was doing enough of this where I realized that I was transferring patients, not very often, but every so often I was transferring patients simply because I didn't have a complete examination, which for me in these kind of situations included deep tendon reflexes, sensory examinations, and high quality motor testing, like strength testing of these muscles, that muscle by muscle. So it's one thing to say the arm is weak. It's another thing to have someone tell me specifically it's a bicep weakness, maybe wrist flexion weakness, maybe interosseous weakness. So these specific details at times will help us localize the lesion. And reflexes, as I mentioned, are helpful as well, right? To make the differentiation oftentimes of, is this an upper motor neuron lesion or a lesion in the brain or spinal cord versus a peripheral lesion, like in the nerve, such as a radiculopathy or a polyneuropathy. These type of questions could be answered with an exam. And so when I was thinking about this and going through, I did a good amount of teaching medical students and residents. Neurology is a challenging field. Obviously, all the fields have their nuances and challenges, but neurology, this localization element, it's not easy to teach someone. That's why there's a 3-year, 3 to 4 year residency for neurologists to become even board eligible in the United States. And so that's complicated. And I realized that I could teach someone exam elements fairly simply because I kept on doing this with my medical students and my residents. And so I could teach someone to elicit high quality reflexes, check a Babinski sign, and check the strength testing at a pretty good level, and sensation, a detailed sensory exam, for example, checking vibration versus pain and temperature peripherally, as well as checking for things like a sensory level to help establish if there's spinal cord pathology, for example. And so I figured if we could really get people on the other side to help me out, then I really won't need to transfer anyone. Transfers are a tricky thing because you can imagine these folks are coming from 2-3 hours away oftentimes in these spoke hospitals. They're out there. And I would think it's probably not dissimilar in Sweden because it's a fairly large country, but I don't know about the big tertiary centers. And basically you have a chance to keep the patients there with their families in their local communities. And it's also expensive to transfer. I mean, there's a fiscal cost and also just a patient care element that most patients would prefer to be in their local hospitals as long as the care is adequate. That's what I found. And so that's what led me to thinking about this. And then I thought to myself, what I was seeing over and over again, mainly was situations where sometimes you see patients by themselves. They roll in the video machine, the cart, and you speak to them like this with no assistance. And then sometimes you would have them in there with a nurse. A nurse would be there, but the nurse would help out. I would walk them through the examination. But the nurse was what I would call an untrained assistant. They're trained, they're highly trained to be nurses. They're not trained in the neurological examination or the orthopedic exam, for example. And then I realized that every so often I would have some individual on the other side that had some background in neurology. They may have done it in the past with someone else. Most often in the US, it was either a physician assistant or a nurse practitioner. And so to me, that made sense that these individuals, could help me out with more detailed exams, including the sensory testing and the reflexes, and I could watch it on video. And I get a decent idea of the quality of it. And that would really help me make these decisions on what to do. If they were stable where they were, I would offer treatment where they were if I could. And if not, then I could transfer them for more intensive care. So that's what led to this, is just understanding that there was a need for individuals on the other side. And the thing about it is, these folks like physician assistants and nurse practitioners are very skilled. They take years to train also. They're pretty expensive in terms of the overall model of care. And then at the same time, they're also trained to make medical decisions. But in this case, what I was really looking for is just someone to help me with my physical exam at a distance. I was happy to continue making my decisions. And that's what led to me that I figured we needed these examination assistants trained at a high level, simply to help extend my care to different places. And that's what this paper is all about, basically.
Okay, so do you think that these examination assistants should be nurses, for example, or should they be people just at a high school who want to go through this short education specific for the physical examination in question and then be able to get a job helping doctors with the physical examination in particular? Or who should do this job, do you think?
So this is a great question. First of all, I think there's a way to answer this more academically by actually putting people through a training program and see how they pick it up. But from my gross understanding, just thinking about this, I think it could be what we call allied medical professionals, like even respiratory technicians, nurses. And in the U.S., we have these like nurses' aides to help the nurses, and even nurses' aid. I think you could teach them a lot of this. So I think it's less important in terms of who's doing the exam, but more importantly in terms of the quality, in terms of the training of these people. So as long as they could go, so the way I envision it is that you train someone to go through this, and the trainers are the neurologists, and you have some neurologists who train them, and then you have neurologists that eventually do a final examination, blinded neurologists that look at the quality of examinations. And then in the hospital I was working at, for example, there was a rehab facility associated with the hospital, an acute rehab center. And so the rehab center is nice in the sense that these are a lot of stroke patients will go there, and people who fell, and basically the patients there have pathology. It's one thing to train someone on a normal examination, which is fairly easy, but you want to make sure they could do these maneuvers on patients with actual problems. So the patient's going to have hyperreflexia or increased reflexes. They can't feel one side already. And so I think you train them in these facilities. That's the mechanism. And then what I'd like to do at some point is a proof of concept study to put individuals in these kind of facilities. Put these trainees there and figure out what's the end. How many cases they need to do until they're comfortable. That's a question that needs to be answered formally. And I really do think that a lot of folks could be trained in this. It could be nurses also. It all depends on these ratios. In the U.S. in particular, I'm not sure what the situation is in Sweden. How in the U.S. the issue is these nurses may be covering 5 to 10 patients, maybe sometimes more. And so you need individuals who have some time, a little bit more freedom to do this, because it's going to be hard to get them to do this during the course of a day. Ideally, it could be, even high school students that want to get experience, maybe. We already have individuals in the U.S. that are scribes. They have scribe programs. They'll go in with a doctor into a room and start typing their notes as they go through the examination. And so I think the scribes themselves could be high school, college grads, fairly young, as long as they're motivated and they understand patient privacy and safety, general safety, hand washing, these kind of things, which I think they're capable of. I think you could train them. But as I said, David, I would try to prove that specifically. It's important. And every person has to really be good when they graduate a program like this.
Yes, of course.
And the one thing that I think is important to mention, I think this is going to change also in the next 5 to 10 years, maybe even faster, with the advent of AI, with computer vision type programs. So there might be other ways to approach this with other proxies for physical exam, which I anticipate should be there over time.
Can you elaborate a bit on that?
I'm sorry?
Can you elaborate a bit on that? Like, how do you think computer vision could be used to facilitate telemedicine physical examinations?
Well, I think what you'll see, particularly motor examinations, is that you'll see most likely asymmetries in movement of the limbs, as well as the face of someone speaking, right? And you could have the computer prompt the patient, as long as they can hear and see the interface. That's the limiting factor. You could have the individual smile, look up and down, left and right for eye movements. You could have someone speak, repeat sentences for things like aphasia. You'll be missing sensory, for example, and reflexes, but you probably get half of what you need for now. But eventually you're going to pair that with robotics, right? And once robotics are there, well, then these robots with AI could probably pair together to do some of these reflexes and some of these sensory testing and such.
Yes. This is very interesting. And I could already see how it would be possible with today's technology to create instructions for example, neurological exam that are standardized and tested to be understandable for most patients. And I could definitely see the value of that as well. Do you think that could be an alternative solution for the instruction part as like an alternative to these trained certified assistants?
Yes, I think there's some downsides with all these robotics and AI, and upside. The question is ultimately for the world is going to be a matter of cost and acceptance by communities. With a robotic interface, will that scare patients who are especially older, the geriatrics? That's what I worry about. And do we lose something in terms of the physical touch and connection between the caregivers and the patient? I think that's also important. That's sort of the downside. But in terms of interoperability and in terms of having consistent results, it can be very, very efficient, I would think. If the cost point is reasonable for most societies, it'd be really good, I would think.
Yeah. I mean, I guess it depends on what part of the physical examination, like for example, the neurological exam we're talking about as well, what the optimal and most cost-effective technical solution could be. I mean, for example, a small device that makes a sound at a certain decibel level might be an effective way to test hearing, whereas reflexes that are conducted by robots, for example, might be a better technological solution for.
That's true, and sometimes again, in neurology, again, if something's coming as a stroke, then the sensory examination in terms of vibration versus pinprick and reflexes may be less relevant. You may not need it. So maybe you have the doctor on the video end pick and choose who needs what. Because for me, when I'm doing these kind of consults, someone has a stroke that they have a stroke. It doesn't typically matter that much. It's really the other things like neuromuscular disorders, polyneuropathies, spinal cord injuries, these type of things. That's when the differential gets more complex, where you might need to really make a quick decision to see what they need, whether it's spinal cord decompression, MRIs of the cord, things like that, versus like Guillain-Barré syndrome, where you need to initiate things like intravenous immunoglobulin therapy or plasma exchange. So that's where you need it. But stroke, they come in with a stroke. If it looks like a stroke, they're usually very hyperacute to onset of symptoms. That's part of that tempo part. And if they're paralyzed on one side, you pretty much have a good idea. And nowadays, with the modern imaging in stroke, we have vessel imaging, which will show us major clots in vessels, and then we have things like perfusion imaging that's also been widely adopted across the world. That will show you ischemia, acute ischemia. And so for those patients, you may not need it. You can pick and choose the patients, is what I'm saying, and depending on what your differential is. And the expert should have the idea what the differential is.
Yeah, of course. So you mentioned that you have this idea for a new study, I think, that you want to carry out to test the idea of certified.
I'd like to do it.
Yeah.
The first question I have for myself is, what is the end? How many exams does someone need to do with an expert until they're comfortable actually doing it? It's actually the same question I have even for medical students on rotations.
Yeah.
Because you see medical students with a wide range of skill set with this, especially in neurology, where there's a little bit of a neurophobia. People are a little bit scared of these neurology rotations. And then you see, oftentimes I would see medical students towards the end of their rotation. If their rotation, let's say, was 6 weeks or 12 weeks, you can see some of them are flying through it. They're great. And others are still having a hard time. So then I wonder, and oftentimes if I would spend a good amount of time on physical exam education. So they come in early, I'll sit there and I'll go through all these exams pretty thoroughly myself, and then I see that they're really growing. That's another part of it. I can see how to train someone doing it. But sometimes they don't get that. So I want to know what is the optimal number for the average student or average person to pick up the exam elements. So that's really the study. I mean, part of it is qualitative. It's quantitative and qualitative, where you would ask the student, "Excuse me, do you feel comfortable with the exam?" And then you could see then you have some sort of rating system by experts during the course of their training to see when they're actually what's the learning curve, and establish the learning curve. And once you have that, in medical students who are going to be experts as they mature in their careers, then it'd be interesting to compare that to maybe a nurse or these now like a respiratory technician or a high school student, a good one that you mentioned. And then you could really pinpoint what you need. What are the resources necessary to train these individuals? Unfortunately, and this is what it is in the U.S. for sure, everything comes down to dollars too, where it needs to be cost effective. It's very hard to bring any initiative that's not going to pay for itself. Ultimately, with these situations, the cost savings is a transfer.
Yes,
that's the
of
big
course.
savings.
Yeah. So the transfer of the patient. Yeah. Okay. What factors do you think would be important to focus on in order to reduce the costs of
well, I mean,
the education?
The biggest factors ultimately are providing top level care at the spoke hospitals. And in this case, this is part of it. Another example that we have in neurology, which is a big issue we run into commonly, is something called video EEG monitoring or electroencephalographic monitoring. So basically, people come in with events that may or may not be seizures. They may or may not wake up. And if they're not waking up, it's very hard to say, are they still having silent seizures in the background? Or are they in a phase that's called a post-ictal phase, which just means their brain is sort of resetting after the initial seizure. That completely changes care, because if they're post-ictal, they don't need anything else oftentimes. You might start them on seizure medication, but there's nothing really to worry about. That's a normal part of a big seizure. But if they're still having silent seizures, they're in a dangerous place. They could be in something called status epilepticus, even non-convulsive. So they're not having any convulsions, but they're still seizing, and that's dangerous for the brain. In those situations, you really want to diagnose and treat. And so the treatment is primarily IV anti-seizure drugs. And so in those situations, what ends up happening oftentimes is folks get transferred to these big epilepsy monitoring units in the United States to put them on continuous EEG monitoring, which is basically putting the electrodes on the head and keeping it on for 12 hours or 24 hours or as long as necessary. And what ends up happening is a lot of times in these big setups is that individuals get transferred just for this reason. But now we could do remote EEG monitoring, for example, and then if you're able to see if they're seizing or not, you'll need to transfer them. So you keep them where they are. You could treat them completely at a high level at the spoke hospitals, and that's all you need. But even then, it's complex. Even that, it seems like it will be pretty easy. But then the question is, who's available to put these leads on, and what kind of leads do you have? And there are devices that have been made that you can just put on, almost like a hat, which is pretty accurate, and it will tell you if someone's seizing or not. And that's one solution. So that I think those are the big savings you get, and improve care. The key is top care. You need to make sure the patients are always getting the best care, regardless of location.
Right. That's the top priority, of course.
Yeah.
But so I'm not sure I understood entirely what the key factors for reducing the cost of the education of these certified assistants would be.
Oh, the cost of the education. I mean, I think one thing is you have to look at who the assistants are and what their general base pay is. Because if you have like physician assistants or nurse practitioners in the United States, their base salary is relatively high versus maybe a nurse assistant. So if you're paying for training, which you probably would be paying them hourly per training, versus a medical student versus a for example, a high school student, as you mentioned, or a college student, the pay correlates pretty well with their level of training and stuff to begin with. So I think if you could figure out exactly what is the lowest or common denominator, what is the individual that has the least base pay coming in and still could achieve the goal, that's probably going to save the most money financially with the training. And then everything else, you still have to pay for example, you need to have a good system for the doctors. You still want to have good doctors training. And so I think there you have to find folks who are dedicated and interested in the process to improve this thing. Like, in other words, a lot of neurologists I know would most likely do this pro bono. They would just do it to increase the care. Because by doing this, it also makes my job way easier and better in these settings also. So there is a secondary gain as well for the doctors.
Yeah, and you think there are enough interested doctors for this process as well?
Well, David, I have not done any formal surveys. I'll put that as a disclaimer. So I think there would be, because most of the neurologists I do know they're a passionate bunch. Most people are, if you're in the field, they're pretty passionate. They enjoy neurology and they enjoy offering top care. So I think there'd be enough. But that's an interesting survey study that can be done also.
Yeah. Have you gone past the idea stage as regards this next evaluation study for the concept of certified assessment?
Yeah, I have a white paper that I create for myself, basically pretty much how we would train them and how many folks we would need to do it. It's a whole thing, because from my perspective, especially to start off, we need a grant application, which you get sucked into. Takes a good amount of time, and I've had some other things going on in life.
Yeah,
so
I see.
But my collaborator, Dylan Cohen, he was my student. He's a neurologist now. He's about to graduate residency very soon, and he may help take over that stage. I'm hoping, at least.
Yeah. And what's the grand picture vision here? Like, what do you want this project, this concept of certified assessment assistants to be? Where do you want this idea to end up in 10 years, let's say?
I mean, what I'd love to see is someone to take it and actually answer some of these questions with what is the end in terms of how many exams you have to do, and put it into action. Whether it's me or someone else, it's a little less important, but I'd like to see someone do it. Do a proof of concept. If we can show that it works, then to actually see it on the field. So I'd love to, I do a lot of telework myself, so I'd love to be able to log on to a hospital and know that I have support on the other side. A random hospital in the United States. That'd be great.
Yes. Do you know if there is any data on whether this saves, like, is this cost effective if we go one step more meta, so to speak, and analyze, okay, so if doctors can engage in telemedicine, I mean, of course, it's cost effective in comparison with transportation towards a distant site, for example. But even just...
I think it's a great question, David. I think long term, what you need to do is really figure out what is the cost. And that can be a function of how many exams you do. The good thing is, as I mentioned, in these rehab facilities, the patients are there. I don't think you need to pay the patients. I think you just need to pay the facilities, or maybe reimburse them to get access to the patients, which I wouldn't think would be very much in the grand scheme of expenditure. And then once you're in there, because most of these patients are sitting there lonely anyway, and so having someone visit them and spend some time with them and potentially improve their care anyway, I think there's a lot of upside there. And so once you have that cost, then you can really do an economic analysis, which it needs for sure.
Yeah. Do you think that there will be a day when, I mean, I guess there already is a smaller version of this happening. So in Sweden, at least, we have this, like, for example, in patients with chronic kidney disease, oftentimes they have, and other patients as well, but there's this concept of 24-hour blood pressure monitoring at home, like ambulatory blood pressure monitoring. And then after the patient has done that at home, then they come and visit the doctor again, and the results are discussed. Do you think that there will be a day where this concept is extrapolated to the point where there are many different measurements carried out automatically on almost everybody in their homes, and like wearable devices, etc., etc.?
I mean, I think it's going that way, especially for things like dementia and different neurodegenerative disorders, Parkinson's and such, where you may be able to detect early changes just by analyzing voice patterns. So if you have microphones, for example, in these settings, you may be able to see changes early, preclinical changes. But then all those in those situations, you're always going to run into privacy concerns in general.
Yeah. Of course, it would have to be something that the patient has explicitly agreed to. I didn't know that part about voice recognition in Parkinson's, for example.
Or even gait changes. You could easily have, when again AI looking at people walking down a single hallway in the home that they walk by every day, gait changes, and that gait change may be indicative of both degenerative disorders or stroke. If someone's walking and all of a sudden you can see that they're circumducting one leg, and you can see that they're swinging it in a not typical physiological manner, then you might be able to recognize an early stroke. Or even not just the voice quality, so you could hear something called dysarthria, or changes in the voice, which could also be indicative of a stroke or neurodegenerative disorder, or you may even hear aphasia, depending on how complex this AI is. If all of a sudden individuals are losing words, or their sentence structure is different, again, you may catch a dominant hemisphere stroke early.
Yes, and to clarify, is this through video cameras that are always on in the home, or how would this be detected?
Most likely. I mean, it depends on what you're looking for, but I think if you're just looking at voice patterns, that's just the audio. But if you're looking for changes in gait in particular, then I think polymodal probably will probably give you the most data, right? Like audio and video both, you see more. I mean, if you want to get really complicated, you could even have a special pen where someone goes and writes a sentence every day. And you can see if there's tremor, how that fluidity of motion is there. And so it all depends on what level you take it at. Again, going back to cost efficacy. And eventually the cost efficacy question is always complex because it's also a question of disease modifying therapy, especially in degenerative disorders. So let's say you find something early, can you change the course of the disease? In stroke, the answer is absolutely. But in other things right now, it's still debatable.
Yeah. And so then I guess there would be, because you mentioned AI would be integrated into this hypothetical system. I guess there would be an AI setting limits for, okay, this pattern right here, it suggests there is an indication for a human doctor to look this over.
Yeah, that's why I think we have to be some sort of hybrid for sure. I wouldn't be comfortable with AI making all the decisions.
Yeah.
But I think in terms of spotting trends and then notifying an expert, I think that's the sweet spot.
Yeah. Do you think that telemedicine could, so an entirely different topic now, do you think that telemedicine could be used to facilitate access to healthcare in underserved areas? Like, for example, very poor countries with few doctors per citizen, for example. And how do you think then, if you think so, that can be facilitated?
So this is a tricky question and a good question, David. In general, I think the answer is yes. But you have to look at both the connectivity in these countries, which may be limited, and also the individual's own, what the penetration of these devices in these communities, which I'm not aware of myself in countries outside the United States off the top of my head. In the US, I'll tell you that even if you go to some of the most indigent areas in the United States, most individuals do have smartphones. So you're seeing it pretty much everywhere. And in terms of internet connectivity in the United States, that's been a priority for a while from a government perspective. So I think in the US you can actually get really good results from that. But I can't tell you about, for example, Rwanda or South Africa. I have no idea.
Yeah.
Or even South America. It really depends on what people have and its connectivity. You need to have good Wi-Fi and all this. Very important.
Yeah. And
but eventually, you see with Tesla and what was it? They gave Ukraine these what was it? The Starlink devices, right?
Sure.
It's pretty much to give internet all around. So as that technology advances, I bet you will have. I think it's a question of technology and time, but eventually we're going to have capability in, I think, the whole world.
Yeah.
At a reasonable cost.
Yeah. And I think the COVID-19 lockdowns opened a lot of people's eyes to the potential of remote work and also to telemedicine. Do you think that there were any particular steps of progress during the COVID-19 pandemic that were important for medicine's advance?
I think COVID, in 20 or 30 years, we'll look back at COVID in general, and I think we'll look at it positively, other than the mortality itself, in the sense that it pushed medicines forward by a lot. With things like long COVID syndrome, it's really a multi-organ disease, sort of like syphilis did, over 100 years ago, but it involves so many organs that we have to figure out these disorders. And I think once we understand COVID better and some of these COVID-associated syndromes, it'll also help us with entities like fibromyalgia and other sort of autoimmune entities that we don't really understand that well. COVID will ultimately help us. And in terms of adoption, it pushed a lot of health networks, especially in the US, to incorporate more telemedicine because they had to. And ultimately, with infectious disease, you don't want to bring someone into the clinic for something they could do at home and not expose the staff and other patients. So it pushed everyone towards telemedicine. And it pushed, again, I hate to say it, but it pushed the payers to cover it. It's very tough fiscally if the payers aren't, the insurance carriers and the government's not willing to pay for the services. It's very hard for clinics to adopt this, especially in the US, because then you have to keep your lights on, basically. And so it was like a kick in the butt because we've had the technology for a while, but there's a lag time and pretty slow adoption period. And so I think COVID definitely pushed it. Like in neurology, we've been using telemedicine for stroke for a while, and successfully and very well validated, but we weren't using it as much for office visits. The reality, if you already have an established Parkinson's patient, for example, is there a big benefit of having them walk to the clinic or take a bus and walk over? Well, when they had COVID, you didn't want them to walk over anyway because there was risk associated with the office. So you say, stay home. And then the insurance will pay for it. We could do a video visit and really get very similar results as an in-person visit, especially these established patients.
Yeah.
New diagnosis. I think the patients that need new diagnoses of issues, hospitalized patients, or even these neurodegenerative patients, they're the ones where these assistants can really help out. Because then you're able to really, get diagnosis down. But COVID pushed everyone forward. But I think a lot of it started with the billing part of it. Also, again, I don't know, Sweden. What did that look like in Sweden for you guys?
The billing aspect of
the whole adoption of telemedicine with COVID. How did it influence it?
I know that Sweden was pretty early with telemedicine. Well, I think so, at least. I don't know in particular when the US started, but I know that the first internet doctor services were available in Sweden by 2016, and then in 2017-18, the regulations were more like they are now, because in the early days, I remember, and I've read about this as well, that there were these very liberal regulations, and so it was very easy for the companies to charge a lot of money for the patient visits through online meetings. But then within a year or so, those were updated, the laws.
Is there? I mean, I would think there's probably a pretty big geographic spread, no, for the patients
in Sweden?
Yeah.
Yeah, especially in the north of Sweden. Yeah, very big, indeed. And I think, as in, to my understanding, the rest of the world, including in the US, also in Sweden, telemedicine was, well, it became more prevalent during the COVID-19 pandemic.
And Sweden's a technologically advanced country. Also, it will be interesting over time, just about some of the nations that may be significantly poor and have poor infrastructure. How does it help them? Because eventually, I think that you'll have international consults, and you'll have more and more of that, which I think you're probably already seeing in the Gulf states. But the Gulf states are also technologically advanced and pretty well off financially.
Sure. Yeah. All right. Do you think that virtual primary care units that are entirely virtual will be a thing in the future?
I think people are going to try it. It's just, again, the human connection is what I worry about. Are individuals going to feel as comfortable in a setting? I'm not sure.
Yeah.
And so I think there still has to be humanism involved in medicine. And so if the population is willing to adopt this, then yeah, you'll see it. I think from the physician end, it'll make sense as long as the care is as effective as it can be, but we'll see.
Yeah. Would you say that the connection part and the, well, eye contact and like just being present in the room and the trust that can build between patient and caregiver and care provider, do you think that that's the most important negative aspect of telemedicine in comparison with meeting the patient in the same location? Or do you think that there are other negative aspects of telemedicine as well that are important to mention?
Those are probably the major negative aspects. Adoption, and you need to make sure the patients can hear and can see the interaction, which you may miss. And then you may miss other people's reactions. Like if I go in the room, I'm of course examining a patient. A neurological examination begins the second you see the patient. Even before you touch the exam, you're looking at the movements, at their their speech patterns. You're looking at everything. Also, in a more nuanced setting, you're also looking at their families, the caregivers. What's the relationship with everyone? And that part you may miss, depending on where the camera's located. But we haven't touched upon this at all, David. But the next step, at some point, I would think you'll have some VR associated with this as well. I have my Oculus somewhere in a different room, but you can see there might be a VR interface with some of this stuff.
Yeah, I like how you're thinking. I actually, in preparation for this conversation, went through some potential variations of how telemedicine could be implemented in the future, and that's something that I also thought about. And there have been several aspects like AI and others that we've mentioned already that I already thought about asking you about, but then you just mentioned them in the conversation anyways.
Right.
How do you think that VR could be
Well,
implemented?
VR may help with that connectivity element also, because it does make you feel, I would think, closer there with someone and it could potentially solve some of these issues of seeing the family and other people, the whole scenario. So I think VR could help. And especially if you think about VR combined with some sort of robotics on the other end, that you can, not dissimilar from surgeries, like a virtual surgery where you control something, you could really, you check your own reflexes, you just control the humanoid or whatever you're using.
Yeah, yeah. You mentioned telemedicine is used in stroke care extensively. Can you go into that a bit more in depth? Like, how is it used currently?
Yeah, I mean, stroke care, to put this in perspective, we care about a couple of things when someone comes in. I mean, we care about the whole patient, but the key factors are, when was the onset of symptoms, the exact time, which oftentimes may be, when did you see a change? Or the questions you ask, when did you see your family member last normal? Okay, and then what happened? You know, oh, they were playing guitar. And then what happened? Well, then they couldn't play the guitar anymore. What time was that? That's very important, because most of our therapies are very, very time sensitive and time limited to some extent, you know. And then you want to find out if they're on the blood thinners. This is very important because it affects, can we give these patients clot busting medications? And then you want to have an idea of what their deficit is. So the tele part of it is looking at deficit, for example. So that's we use something called the NIH stroke scale, which is a very, very quick and dirty examination of a patient that correlates pretty well with how big of a stroke they might be having. And so that's why I'm saying the exam is very simple, and it's pretty much it was developed for anyone to administer. Anyone, meaning it could be EMS, doesn't have to be a doctor. It could be emergency medical service. The certification is easy. You have someone smile, you have them look around, you check their visual fields, and then you put the arm up for 10 seconds, the leg up for 5 seconds, and you just look for drifting. So it's pretty easy to score. And so when you communicate to someone, when you call an expert about a stroke, those are really what you need to know. Is when did it start, what blood thinners they have, and general history, you know, what's their baseline function, and the stroke scale, what's the severity of it. The higher number, the worse the severity. So that's why it's been used so much, because that's all you need to do is we'd be making virtual decisions with these patients even before seeing them on video. And now what we have video connectivity like this, which is pretty good. They come in and you could tell them this, you could get those exact factors pretty well and pretty accurately just on video. And that's why the adoption's been widespread. And the stroke has been a big initiative by the American Heart Association and a lot of organizations in the US, and I would say internationally, to increase stroke care and to bring these proper treatments, you know, in terms of thrombolytics or medications that break up clots. You know, there's no time to transfer to the hub hospital. So what a lot of places adopted was something called drip and ship. I mean, they would give the medication on the field and then ship them over to the bigger centers for further care. That's changed a little bit now to some extent, because now we have something called vessel imaging, which also shows us clots in the blood vessels. And we know now that the blood clots in the vessels can be manually extracted by interventional neuroradiologists or neurointerventionalists. And so stroke care is perfect for this. Nowadays, what we have ambulances. Most people don't, but there are ambulances that exist that have CAT scans in the ambulance, because if you could check a CAT scan and show that there's no bleeding in the head, maybe 15-20% of strokes are hemorrhagic strokes. Those type of strokes, you definitely don't give any extra blood thinners to or clot busters, and so that's the other element. So now the whole thing can be done remotely. You do a CAT scan in the ambulance, CAT scan, exam, and decision making, and then you have a nurse put an IV in, for example, and give them the medication. And really, they say time is brain in the saying of stroke. So every minute you're losing more brain cells. So you really want to get the medication as soon as possible.
Yes, and so the remote part of this is that the doctor is not with the patient, but other healthcare personnel are.
Yeah.
Yeah, right.
And that's been shown to be effective. And actually there's, so last I checked, there were 2 ambulances in our area, like in the area in Pennsylvania where I'm at right now, that are enabled with this CAT scanner and are mobile enabled, sort of mini stroke centers. But there's other problems, David, with that. And the question is, who gets the ambulances? Which patients it gets them? Where do they go? There's other questions that arise in this, in terms of distribution of resources. It's not simple.
Yeah.
And do you even use it in big cities? If you're in New York City, do you need it? Because there might be a hospital 2 blocks away, 4 blocks away. It might be faster just to get them somehow into the hospital and do it there.
Sure. Yeah.
So I think every scenario really needs pretty extensive look at the actual local variables. But with this assistance, if we could prove that the assistance can be trained, can you train someone who's not an advanced practice provider like an MP or PA or a medical doctor? Can you train someone to do these exams remotely, and can that ultimately affect these transfers and offer individuals this care remotely with an expert on the other side? If that concept works, then that's great. And then you could see in any location how that factors in, based on the internet, based on cell phones, whatever, all of it.
Yeah. Other than stroke, what are some neurological conditions that have? Well, I think you mentioned that stroke used to be a condition where telemedicine was adopted extensively in comparison with other conditions, but now it's more of a peripheral condition in regards to which condition within the field of neurology is most extensively has most extensively adopted telemedicine. Did I understand you correctly there?
Yeah, and nowadays you could offer a full neurological. What you're seeing now in the U.S. at least is that really a full neurological service offered remotely, full service, almost any pathology. And it's just there's limitations without the exam assistance. So you work with what you have, and neurology is very history heavy. So with this kind of communication on video, you could really still get a very, very good history from the patient, from the family. You have to take your time, review the records in detail, and call family for collateral information. These are all the things that can be done remotely. Where if I work on telemedicine, I'm seeing every type of patient. And then the things that make the most sort of easy sense are seizures also. Someone comes in with nuance at seizure, there's no question we do remote EEGs. But those are 20-minute studies, maybe half-hour studies, 40-minute studies. But the ones that are more complicated are the ones that aren't waking up that you might need to do continuous monitoring. But even though it's continuous monitoring is there. And the continuous monitoring now, it's not just the EEG, it's a video EEG. So you're getting live video and the EEG. And this is good because if the person's having some sort of twitching or any other abnormal muscle movement, you can see it on video. And you can really correlate that with the brain findings on the EEG. That's very much similar to what we do in person. So that way you could offer top care if the peripheral center has a good quality MRI, which most of them do in the United States, then you could really offer everything you need to offer. Yeah, and the only reason you transfer is for maybe neurosurgical intervention at the hub hospital if you need it.
Right.
For now, but in the future, maybe we have like I said, the virtual surgeries. I mean, this is all very rapidly evolving field. It is exciting.
Yeah, I agree. It's exciting. So currently, neurosurgery has just been tested in some instances, but it's not widely adopted yet.
Yeah, I'm actually, I need to look at the literature to see about this remote neurosurgical intervention. I'm not sure. My understanding was more general surgery that they've definitely done. Maybe even cardiac surgery. I have to look at this.
I see. Okay. I've written down some other, maybe a bit more far-fetched ideas as regards how telemedicine could be developed in different directions, and I'm wondering, do you think there's any use for blockchain technology to increase the security of, for example, prescriptions? Would there be a need for that, or do you think blockchain technology doesn't really have any application within telemedicine?
This is a great question. I never really, I mean, I'm mildly familiar with blockchain technology, so I'm certainly not an expert, but I have some family members who are very deep in blockchain. I'd be curious to ask him what he thinks. My stepbrother David. I mean, the folks that I know that are involved in blockchain, they're very enthusiastic. They can help across many fields, especially financial transactions and such. Here with prescriptions, it seems like it may be useful, but again, my own level of knowledge here is limited, so it's hard for me to give you a very useful answer. What are your thoughts, David, on it about blockchain with this?
Yeah, I don't have in-depth knowledge about it either.
I will tell you, there's one problem that actually my co-author Dylan Cohen identified maybe a year ago. We were talking about it. It's a big problem in the U.S. that when you write a prescription to one pharmacy, everything's via the electronic medical record. It gets sent to one pharmacy, and then let's say you decide to go to a different pharmacy. It's a major hassle to take the prescription and get transferred to a different pharmacy. It really is. You have to jump through hoops, get the script rewritten, resent. Maybe that's the use case of blockchain. Maybe,
Yeah. Exactly. And that's the kind of use case I was thinking about. And I know that sometimes it's hard to get journals from private sector, companies that provide healthcare into the more public healthcare journal systems. So maybe there could be some system developed using blockchain to automatically verify the identity of the patient and connect it through some blockchain technology to the different journal notes.
Well, that's a good point, because there's also, medical publishing is the major pain in the U.S. at least, and so maybe blockchain can help make that process a little bit. In terms of if you get rejected from one journal, resubmitting it, there might be some, and then also referencing and citations, all that stuff. There might be multiple uses. But I think that's probably a better question for an expert in blockchain also, and then to come together like a multidisciplinary team talking about this, like someone like yourself, like a medical person and a blockchain expert, and sort of think about what kind of utilization it can be.
I agree. Yeah. So you mentioned that for every specialty, you think that telemedicine can be integrated in some way. Do you think that there are any patient subgroups?
Oh, well, think about it. Even ENT, they use scopes. The other day, my partner Jennifer, she just ordered an otoscope. That'll basically show, and it's pretty safe. It's very soft. You're not going to rupture the eardrum, and it'll transmit virtually. It even has a little vacuum for CERAMENT. But aside from the vacuum, you could definitely transmit the tympanic membrane and everything. You can see it, and so there might be some gaps in training that you need to show folks, but there's a lot there. If you can auscultate and if you can look, you could really get a lot of exam elements there. You could probably use anything up to ultrasound. Ultrasound is probably a limit where it takes a lot of skill to operate.
Right. Okay. So that was actually what I was going to ask. Do you think that there are any subgroups or any particular tasks where it just won't be possible to integrate telemedicine, or do you think that everything is possible to, with the right technology, to integrate it so that you can, at a distant site, carry out the intervention or the diagnostic method.
Yeah, I'm of course a futurist in some regard, David. But I think I think it's a function of technology. If you have the right VR and the right sort of robot on the other side, you really could do most things. In other words, something that's very pressure sensitive. So if I press a little bit down, it'll give the same pressure to if I'm examining someone's abdomen, for example, and I can feel the feedback. In other words, if I can feel if an abdomen is rigid and these type of things, then you can really do most things. But in neuroscience, I think you can pretty much do everything you need to function. Again, we need to confirm with the neurosurgeon, but this is if you're able to offer most surgeries in the body, I don't see why not.
Yeah, that's very interesting. Like you just opened my mind there through the pressure and feeling the abdomen rigidity. Like you could.
Yeah, we need
like,
tactile feedback, right? It's important because
Yeah.
even in neurology, you're checking tone a lot, and so that tone you want to feel it. If there's cogwheeling and it's a Parkinson's patient, you want to feel. You could see some of it visually, but you want to feel it ideally.
Yeah. Do you think that there could even be like a 3D room? Like if there was a room with like all sorts of cameras and sensors. Now we're talking way in the future, where you could, for example, go into the like the room just takes the shape of the particular patient's abdomen, and the surgeon could just, like, as if they were painting the room, they could have a lot better detail of you, and then they could cut in the wall, etc. Like,
I mean, it sounds very interesting, David. I don't see why not, but again, as not being a surgeon, I'd be curious to see what a surgeon says about it.
yeah, of course. All right. Do you think there are any current appropriate evidence-based methods for prevention medicine at a distance through telemedicine?
Well, sure. I mean, the other model we just spoke about with some of the sensors in someone's home could pick up, for example, neurodegenerative disease, I think, pretty well over time and validate. Then you're talking about eventually, if you're talking about preventive medicine, you need to be looking at some other variables, biomarkers, other biomarkers, whether it's through the eye or other things like that, where you're getting information on someone's cholesterol levels, other blood pressure you mentioned, all these factors. And I think the more technology advances and the easier it is to obtain this, the more the more we can get information from. They don't need to leave the house. It's tricky though. This field is very tricky because are you familiar with the whole nightmare that happened with Theranos, this company with the blood testing?
Was it the one drop blood testing?
Yeah, the one drop. I mean, in general, the idea is wonderful if it was real. I mean, if they were able to do it. But if you have something like that, then maybe in the future you could do mostly things at home. I mean, now probably the best example that I've seen, which I thought about years ago before it came out, is actually a continuous blood glucose monitoring, which I think is very interesting because it really gets the blood glucose from the interstitial fluid when they put these things on. So, what other factors can we detect from the interstitial fluid? I'm not a sort of a bioengineer at that level, but this would be an interesting question. What else can we ascertain from these things? Because they're very easy to put on. We see that from diabetics. People put it on no problem. So if you have something like that with continuous monitoring, or if you do it once a month or quarterly, some sort of maintenance program, then maybe you eliminate the need to go into the PCP that often. And then with screening programs nowadays, anyone who smoked in the U.S., my understanding is the recommendation that they all need a screening CAT scan of their lungs at some point to look for any sort of early lung cancer. So you could probably do a lot of this or a lot of setup for this remotely, and then But is that all positive? Do we lose this doctor-patient relationship? Which I do want to emphasize. I think it's special, David. So, but I think you could get a lot of stuff done remotely.
Yeah.
I think you can.
Yeah.
And then all you do is you do a body screen with your phone, for example, places like Australia with high levels of skin cancer, and you have an AI look at that, and then you do it every 6 months or 3 months, whatever the critical time is. And I bet you the AI will probably do a better job of recognizing any new lesions, even better than dermatologists. Like you could see change, which is very nice.
Yeah.
You
Yeah.
have baseline levels and change over time.
Yeah. Yeah, indeed. And what do you think are, other than resources, of course, like money and time, and what other factors and challenges do you think there are to faster integration of these telemedicine technologies that we've been talking about?
It's tricky. I think it's the question you asked earlier about what COVID did to adoption of telemedicine. Like, do we need something to really push it forward at some point again? That's not as destructive as COVID, or has it just happened? I mean, to me, from my end, having been sitting in some leadership meetings over time, is that you need to get people in leadership positions like yourself over time that understand the medicine and also have a grasp of technology, because there is a certain cultural gap. And I'm not ageist. There might be some very, very, very sharp 75-year-olds, but a lot of the leaders in the United States of these hospital systems, it's almost like you have in the government, right, where the politicians are fairly higher age, and that age gap may be a limitation in terms of what they can adopt. And so, how do you get people who understand technology and understand the clinical part of it, the care, and still have the appropriate experience? The reason they're in there with higher age is because they're very experienced, right? Which is also a huge benefit. So this is a tricky place to navigate. You need to find I would think leadership in the future has to be younger to some extent in the hospital systems, or at least you have younger leaders that are there that liaison with the older folks that are in those positions to really push things along. Because there's also a lot of sometimes it's not about the people who want to push things forward. From our experience, it's also recognizing the folks that put the brakes on things, and convincing those people is just as important. So there's got to be some savvy negotiations and young folks in leadership positions, and then when you have that, and there's clearly a need. The need is there. It's just COVID pushed everything where we need a very acute need at the time.
Yeah. And I would think that you'd probably have some experience with patients who don't have a high level of digital literacy, for example, and that are resistant to telemedicine consultations and physical examinations, for example.
Yeah,
How do you handle that?
I think from a patient side, because I help out a palliative care company where we have these conversations quite a bit, because a lot of the patients that they see are older, indigent, so they don't have any resources. And some of the people I work with are constantly telling me that they don't want to adopt it. The patients are not going to adopt it. But the interesting thing is that when I push them, I say, just talk to them, ask them, give them the option, see what they say. Across the board, we're getting very positive results. Mm-hmm. So certainly, David, it's possible that you might get some pushback from the patient side, the family side. But from my experience, usually having the access to the professionals outweighs that. And so they appreciate having access. If the access is good and you get faster responses, you don't need to wait 2 weeks to see your doctor. You could see them, you could touch base with them in a couple of days. People like that. And that also increases the value of care. So that's a separate interesting question, is how do you bring it up to patients and families? That's more of a sort of behavioral economics question. How do you present it? It's very important. But I think that particular part of it, you could, if they have the resources like the cell phones and the connectivity, then I think that's something you could overcome. Because if you think about it, like now we're using this Google interface, Google Meet, but people use FaceTime all the time. It's very on iPhones. It's very prevalent. Any community that has iPhones, FaceTime is used all the time. So this is not a foreign concept to be on the video and speaking to someone. So I think as long as you show individuals that they have something to gain from this, you get adoption.
Yeah.
Yeah,
Right.
the places I've run into more issues with has been more from the provider side, organizations, and payment, and those issues, rather than patients. But again, I've never practiced, to your point, in a third world country or a place that where really they didn't have that many resources to that extent.
I see.
But I did
Yeah.
a rotation back in the day in the Philippines, which by no means I would say is a rich country. And from my recall, I did pediatrics there, which is a different field. But anyway, I was there for a few months on a medical rotation. Everyone had smartphones, if I can recall correctly. And this is at least 10 years ago, probably longer.
Yeah. So smartphone.
And they're all on Instagram
prevalent.
and stuff too. They're on social media, so they know how to take videos. I mean, you see it.
Sure. Yeah. How do you, like, first of all, what's the most common arguments from these leaders who are resistant to integration of telemedicine, and how do you respond to those arguments with counter arguments?
I mean, it's tricky, but initially when this happened, I would say that the number one argument was always financial, because they need to get paid. I mean, in other words, they have to keep the hospital and the system's lights on, and which makes sense, right? They do have expenses all the time, and their job is to make sure the hospitals stay afloat fiscally. And so, but that's why reimbursement nationally is very important. But once you get past the reimbursement part, you just want to show that if you could show it's effective and it works well, and then it decreases transfers, and then you have good, in the United States, we have a lot of patient surveys that correlate softly with quality. So after a patient leaves the hospital setting, they oftentimes get a survey in the mail to see if they like their experience, how they grade their experience. And so those kind of surveys from people who are higher up is very important, because that affects a hospital's placement in terms of quality of care. You don't want to, it's a star system, like a 5-star system. So you don't want to be a lower star. So 1 or 2 star people, it's public information. And that could also affect the hospital, good or bad. So if you're showing the people who get telemedicine care, get consistently lower rating, then it's not great. For administrators too, because it decreases the hospital standing.
Yes, I get that.
But
do you know
I think conversely, the evidence is important that if you're able to offer, again, high quality and efficient, quick care remotely, my thesis here will be that no, you'll get good grades as long as
I
they
agree.
understand. That's where I'm coming from.
Yeah. Do you think that there have been any? I guess it might depend on the leaders of a hospital, for example, might want data particular to their hospital with small tests of telemedicine integration. They might prefer that, like a more specific source of the evidence, local to their location. But do you know if there are any such studies? I mean, I would guess there would be.
Yeah, I think all this patient satisfaction scores and stuff, you could break them up by hospital size, by geographical constraints, like is it rural, is it urban, suburban, whatever. You can look at all that. So, and then eventually, once they start doing something like this, you have your own data personally in a few months, and then at that point you can make decisions. Data is there; it's just a matter of looking at it, collecting and looking at it. But it's being collected for sure.
Yeah, and also on the
And for something like stroke, for example, in the United States, stroke, heart attacks, MIs, I mean, all that stuff is very closely looked at, because we have those are all American Heart Association quality standards. If you want to be known as what we call a primary stroke center or a comprehensive stroke center, all those numbers are there. So I could tell you, this hospital with telecoverage had a door to needle time, meaning the patient came through the door and they got their medication within 10, 15 minutes, versus the other hospital with no telecare maybe got 18 minutes. all those numbers we have access to. Again, it's just a matter of looking at them, interpreting them, and spending time on them.
Right, and generally,
I bet Sweden has similar stuff where they have probably pretty tight quality metric. Be curious.
yeah. I mean, I know there are a lot of studies on efficiency in various aspects of healthcare here in Sweden as well. I'm not aware of, I mean, I believe so too, but I'm not aware of any particular telemedicine studies in Sweden. But did I understand you correctly then that the studies that have been carried out within these different specialties that you mentioned, for example, they do in general show that telemedicine does, for example, reduce the time for a standardized process within the healthcare.
Yeah, and it's not surprising, right? If you get a CAT scan in the ambulance and you have everything else up, it makes sense intuitively that they would save time, and they do, because otherwise you have to take the patient, transfer them, through the hallway, put them on a gurney, then take them to a CAT scanner, then take them off this thing on the CAT scanner. That all takes seconds and minutes. So when you're looking at processes that really, where every minute is really important, it's not that surprising. But it's nice to have the studies to back it up for sure.
Yeah. Do you think that there are any other aspects of telemedicine that are important to mention that we haven't covered?
I mean, I think telemedicine, just like AI, it's one of those things right now where, like it or not, it's not just coming; it's here. It's here already, and they'll keep on progressing and advancing. And I think it's important to embrace it and have these conversations like you and I are having to really optimize it and use it for what the strengths are. There are probably some weaknesses, as we've covered a little bit, and yet there's a lot of strengths. And I think it's important to embrace technology. That's all I would leave this on for sure.
Yeah. And would you say that that's, if listeners could take away just one message from this conversation, would that be your message, or would you leave them with some other message?
Well, that, and I would say, keep dreaming. I think the sky is the limit, and you can see that. So, as generate ideas, brainstorm, and don't be, keep on developing things and testing them clinically with some trials and gather the data. Once the data is there, it's hard to argue against it. That's all. That's what I would say.
Yeah, I like that. Where can people learn more about your work?
Oh, I mean, hopefully I'll be publishing some more on this topic soon enough. Like you said, maybe hopefully do a proof of concept. But again, my name is Ilya Bragin. You can connect with me on LinkedIn fairly easily. Of course, if you go to Google Scholar or PubMed, you can read some of my other work.
Yeah.
Or feel free to email me. It's Ilya Bragin, just my name, @gmail.com.
Yeah. Right. Thank you, Ilya, for coming on the Exploring Health and Medicine podcast.
That was my pleasure. Thank you, David. I enjoyed the conversation with you.